My name is Connie Arnold. Can y'all hear me okay? No? I don't know how to see if can you hear me now? I feel like I'm doing the Verizon or telephone commercial. Can you hear me now? So I'm Connie Arnold. I'm an associate professor in the Department of Medicine. And my talk today is about doing research and the lessons that Terry Davis and I have learned along the way about doing research. There's my disclosure statement. For most of us, it's been a tumultuous year. We've had a tumultuous presidential election. I'm like that. I'm ready for it to be over. I used to tell people in the community about 8 years ago, LSU always made the paper in the summer during funding. So you had to live with, I always dreaded the summer. Then it became biannually, because then it was midterm, that we made the paper midterm when budget cuts, and now we make the paper quite often. The other thing that's going on, and has been going on for a while, is research funding is down. It's down at NIH, it's down at our institution, and so research funding has become highly competitive. And so why focus on the research project process? For those of you who don't know, that's Captain Obvious from a commercial. And besides the obvious that this is an academic and research institution, it's required by ACGME for residents and fellows, and it's required for promotion for faculty. And you can tell how tight funding has gotten because I'm going up for full professor this year. In the latest promotion, which you couldn't in the past when I went up, you now get to list grant funding you have submitted for the last 3 years that did not get funded, because they realize how difficult it is to get funded. So what I want to do is kind of walk you through, like I said, the lessons that we've learned about different funding, how you get started, where are you going to get funding. And so for those of you who don't know, I started out 24 years ago as a research associate for Terry Davis. And people who are up here a lot always consider us the Bobbsey twins. Where you see one of us, you're going to see the other one. I finished my PhD from A&M and got on the faculty. In the early days, it was really easy to do research. We used to have med students. We used to have tons of med students in the summer. We'd do a project. IRB was a piece of cake. We'd get it through. Research students, med students would get their research done. Life has changed dramatically. It's no longer done that way. And one of the things that you need to know, especially for residents and fellows, is when you're thinking about doing research, you need to think way ahead. You need to think about the training that you have to do for IRB. You need to think about who you want to approach about doing research. And one of the things that I want to show you is a lot of the research that we've done with fellows and residents included on ours, and for faculty here, how to include residents, fellows, med students, college students. So our research has always been focused on health literacy. And why focus on health literacy? We know that healthcare systems function as if patients have health literacy skills and can advocate for themselves. Clinicians and researchers often fail to grasp the wide chasm that separates what they intend to convey with in written and oral communication, what patients actually understand. And so currently only 12% of English-speaking adults have proficient literacy skills. The demands and expectations of the healthcare system are increasing, and patients must be more engaged. And the other thing that you will look at is, one of the great things about being in the state of Louisiana is we are bad at everything. So you can pretty much pick your disease you want to study and have plenty of evidence as to why this needs to be funded. We're 49th in literacy, 48th in overall health, 48th in obesity and preventable hospitalizations, 37th in cancer deaths, and 47th in diabetes. So we know that health literacy is linked to health outcomes. And so low health literacy has been linked to less ability to interpret labels and health messages, a lower ability to take medication appropriately, less likelihood of receiving preventive care and delayed diagnosis, less knowledge, competence, and skills to manage chronic diseases, less understanding for consent for procedure and trials, lower physical and mental health status, higher ER uses and hospitalizations and readmissions, and higher disease-related complications and mortality. So we could pretty much pick a topic and show you how it's related to health literacy in some way. This is just to give you an idea if you've never seen this before. Faculty who have been here a while have seen this map. This is the map of Louisiana by parish with the rates of adults who are on the lowest literacy skills level. If you notice, Louisiana has no purple parishes. So our research has focused on many areas, and I can tell you that when we started out, the theme was always health literacy related, but a lot of it had to do, where was the funding? We got grant funding from what was called the Louisiana Lung and Cancer Board back in the 90s on smoking. We did smoking and pregnancy. In fact, I did my dissertation on that. We've gotten HRSA funding that looked at immunizations, and we looked at hearing screening for infants, and we looked at immunization shot schedules, and that was all wrapped around health literacy. We've gotten American College of Physician funding, and these are the guides, the patient-centered guides we've developed. So this is about 5 years worth of work. But what I wanted to specifically walk you through was how we got funding related around a topic of colorectal cancer screening and what branched out from that. So why study colon cancer? It's very common in the U.S. It's the third most common cancer, and it's the second leading cause of cancer deaths in the U.S. Louisiana ranks third. We know that colon cancer is higher in Louisiana among all groups. It's particularly higher for African American males and females. We know that there are screening disparities. There's an adherence to screening recommendation is lower than other screening initiatives, like if you look at breast cancer screening. There are significant disparities exist in certain populations. If you live in a rural area, it's much harder to get a colonoscopy. Risk factors for poor CRC screening include low SES, low health literacy, minority race, ethnicity, and rural locality. And there are barriers to screening. Screening information is not patient-friendly. It requires high literacy skills. There's a lack of recommendation and annual prompting, and there in the past has been a lack of access to tests. And so this is a map of Louisiana, and it shows you the screening people 50 and older who have not had a sigmoidoscopy or colonoscopy by parish. Red is greater than 45%. And if you're in the green parish, you have 35% or less. So we know CRC screening is effective. We know that you can predominantly prevent colon cancer if you can get patients screened. FOBT can decrease it mortality by 15 to 33%. But with the FIT or the FOBT, it's an annual test versus a colonoscopy is every 10 years or a sigmoidoscopy is every 5 years. The one thing about the FOBT and FIT are they're appropriate, they're a recommended screening tool where gastroenterologists and colonoscopies are limited. They're also a lot cheaper. FIT test for us to do now costs $25 for a patient. So the first grant we ever wrote was a breast and colon cancer screening. Back in the early 2000s, we had gotten an RO3. In case you're not familiar with that, that is the lowest level of grant on NIH. It's a $50,000 grant. They are what I would say is the starting level if you have no data and you're trying to get started. So we've gotten an RO3 on doing breast cancer screening, knowledge and attitudes here at the clinic. So we wrote an RO1. At that time, an RO1 you got 3 shots. You only get 2 now. So we went through all 3 of our shots, got scored on the last 2. On the last one, we didn't get funded, but they have what's called end-of-the-year money. And that's when project officers go in and fight for you with whatever they have left over. Our project officer liked us. She went in and fought for us. The one good thing about it was she had never lost an argument on funding. So we got funded, which was great for us. This was back in 2007. So we were looking at breast and colon cancer screening in 8 FQHCs. And we wanted to test the effectiveness of a health literacy intervention to improve initial and repeat CRC and breast cancer screening. And so one of the areas that we often research is community clinics, or in this case, federally qualified health centers. And if you're not familiar with what federally qualified health centers are, we have, I want to say to date, over 80-something FQHCs in Louisiana. They're generally located in rural or low-income areas. David Raines here in Shreveport is an FQHC. So they're government-supported clinics that provide services to greater than 23 million people, regardless of insurance status, 44 states, over half of them in rural areas. They serve uninsured, and now it's mainly underinsured, Medicaid, rural. 72% of their patients are below poverty level. And in 2015, 60% of them were designated as the patient-centered medical home. So our target was 5 FQHCs because FQHCs have satellite clinics. And so our target was 5 of the FQHCs in rural North Louisiana. During the study, they did not have electronic health records then, and 3 participated. And so we used some of their satellite clinics in this. And so these are the sites that we looked at. We were in Gillum and Minden, Shreveport, Bossier City. All of these are David Raines clinics. We were in Tallulah, Wisner, Sicily Island, and Leesville. The baseline screening rates at that time were extremely low for their patients. Their mammography screening rate was 5 to 9%. Their CRC screening rate was 1 to 2%. So the bottom line was their patients weren't getting screened. 59% at that time had no insurance, and 89% had visited their physician in the last year. And so the intervention was to make information and services easy to obtain, understand, and use. So they got a recommendation. If they were in 50 and older, they got an FOBT. If they were women and they were 40 and older, they got a no-cost mammogram. We designed the pamphlets and a video with patients and providers. So everything we do when we're developing patient education, we go in and we talk to patients who have that particular illness or going to use that particular documentation, and we work with providers so that it's a joint collaboration. The simplified FOBT instructions, we even simplified the FOBT instructions for them, which is this, that's the test card result down there. And one of the arms had a nurse case manager to teach and support. And so this is just basically to show you the 3 arms. We had an enhanced usual care. You got the recommendation at the kit and a suggestion to talk to your doctor. The health literacy arm, you got the recommendation, and if you were FOBT or if you were mammogram or if you were both, you got that recommendation, and you got the simplified instructions with it. And you watched a little video that was developed with patients that had a soap opera kind of theme that was 2 to 3 minutes that just was encouraging you to get screened and why it was important to get screened. And the final arm was the health literacy nurse. And so you got all the health literacy component, but it was a nurse case manager who actually would follow up with you and remind you if you didn't make your mammogram appointment, if you didn't turn in your FOBT, they would call. So at the baseline, you were handed it in the clinic. Now, patients don't always come back in FQHCs on an annual basis right at the time, so we mailed out the FOBTs at 12 and 24 months. And a mammogram was, a nurse called and set up a mammogram. At that time, mammography was recommended every 2 years at 24 months. And so when you look at the results, so specifically the only ones I'm going to show you today are the FOBT screening completion. And so what you see in the first year, and this is when you were handed it in the clinic by a research assistant, the rates, I mean, when you think about that their rates was 1% to 2%, went up significantly. And there was a significant difference when you had a nurse who would call you and remind you to turn it in. The second year, we start dropping off. Now, in order to be counted in the second year and the third year, you had to have been completed the first and the second to be counted in the third on this slide. So at the end, 47%, there was no significant difference, even though you see there's 47, 60, and 34. This is the enhanced arm. But what I was interested in was looking at, okay, out of the total patients who actually were involved in the study, how many actually ended up getting 3 screenings? If you look at the bottom, out of all the patients that were in it, 10%. So we dropped off significantly, even with the nurse case manager arm. And the problem became the nurse case manager was not sustainable. FQHCs were not going to hire a nurse case manager whose sole job was to do this. And so what this brought about was thinking about what are the next steps. But one of the things I want to show you is, out of this study, we got 13 abstracts. We had medical students who were part of it. We had research assistants. We had fellows who came in and did this. We got 12 and counting papers out of the study. I will tell you that I saw one of the editors for JAMA, I think, came and spoke to the faculty several years ago, and she said, you know, one of the things that irritates her, this would irritate her, is that she liked to have one full paper that had all the results. And my philosophy was, that's great, but you're not going up for promotion. And you're not trying to help students or residents or fellows with their publications. And so one of the things that I would encourage you when you look at any research that you're doing is, how many ways can you divide it up? Trust me, Terry and I can find more ways to divide stuff up because we've done that. We've had to do that since I started here. When you have 5 or 6 medical students working with you, when you have 3 fellows on the same study, you're trying to figure out how can everybody take a piece, can you present at different places? But so that's what we got out of this first study. So the question became, what are we doing to go past this study? And one of the things that we were very curious about, which we were really aware of, is you can get patients to do that FIT or FOBT once, but it's not any good if they don't keep doing it. It's not one and you're done. And so the problem becomes, how do you encourage it in a cost-efficient way? So one of the things we did was we wrote a diversity grant with Northwestern in Chicago. And it was to compare using a prevention counselor, which is just a person who's trained to make follow-up phone calls with an automatic telephone reminder. At that time, you got 3 shots, and we got rejected. That's the name of the game. You have to be able to get used to getting rejected. So then we decided to do another one at the suggestion of our project officer on our R1, who wanted us to partner up with Kentucky, who was doing something with CRC screening. The first reviews that came back, they wanted to know, why were we partnering with Kentucky? Because we had no working relationship with them in the past. Even though we had tried to justify, their population is very similar to ours. They have an Appalachian, very low income, low literate population. They weren't buying that. And herein becomes the problems when you submit grants. So this is the 2 shots and you're out. So we dumped Kentucky with their approval, but that's a nice way of saying we took them off. So you send back in. You have 1 page that you can answer the critiques of 3 reviewers that you're allowed. And so when you send it back in, the problem is that the reviewers are not necessarily, and usually often aren't, the same reviewers who reviewed it the first time. So we took out the big eyesore that they had with Kentucky, and then they got really specific about everything else they didn't like about the grant, and we got rejected again. And that's just the nature of the beast. But in that process, we were working with a grant writing to the American Cancer Society. And The American Cancer Society is a much friendlier organization to write with, and it's just because of the size of it, than NIH. And ACS, you have 3 shots, but one of the great things I will tell you about ACS is they set up a phone call with you after you get your reviews back. The project officer walks you through what the issues were that the committee had and tells you what was said in the room when your project was being discussed. And so if they really like a project, they are really pro on helping you get it funded. And so the third time we got the study, we tried 2 different ways with NIH to get funded. This is a current study we're doing right now. It's a randomized control trial in 4 rural FQHCs. They're all in South Louisiana. We pretty much did our North Louisiana stint. And it's comparative effectiveness. So now there's no issue about giving them the health literacy information. We know that that makes a difference. So everybody in this study gets health literacy information. The 4 clinics that, let me show you where the 4 clinics are. So it's Opelousas, Greensburg, Franklin, and Houma. I didn't update the slide, but. So the materials are similar. We're using a FIT instead of an FOBT, and the FIT is more sensitive and it's more accurate, and patients like it a lot better. For those of you who aren't familiar how you do an FOBT, the old way was you smeared your stool on a card. Patients weren't exactly thrilled with doing that. So the difference is with the FIT, you have like a paintbrush, and you just swirl it around in the water and you dab it on a card and you get to mail it back in with a posted page envelope. And so we use surveys measuring their knowledge and their beliefs and their self-efficacies about CRC screening, and it's going to be administered. It's already been administered at baseline, and it'll do it 6 months, and we gave the realm. And so what happens is everybody gets a health literacy friendly instructions. They get demonstrated how to do the FIT. They are given the FIT in the clinic. The randomized control trial becomes, do you get an automated call or do you get a personal call? We worked with the patients and the providers in the clinic. There is somebody on the automated call is not a robo-type voice, robocall voice. It's actually a nurse practitioner in South Louisiana. We wanted it to sound like somebody that they were used to hearing. The personal call is also a research associate of ours who used to be here years ago and then went to Northwestern and worked there for several years, and she makes the follow-up call. And so if the idea is, if you haven't returned your FIT kit in 4 weeks, you get a call. If you're in the automated arm, you get an automatic call. If you're in the prevention call, you get a personal call. You're offered, on the automated call, it's just an encouraging, this is important to your physician. If you've lost your kit, you can press a number and we'll mail them another one. On the personal call, she just asks them, are there any problems you're having, and do you need another kit? Most time, the majority of patients, they just haven't gotten around to it. They haven't done it. They'll just tell her straight out, I'm busy, life has gotten in the way, I haven't done it, or whatever. We'll wait 8 weeks. If you still haven't done it, then we'll mail another one. We'll call again. So you'll get another automated call or you'll get a personal call, depending on which arm you're in. And then we wait until year 2. The kits go mailed out again, just like in the R01, and then you repeat the follow-up if you haven't returned it. So what we're trying to see is, can you prompt patients to complete their kits in a cost-effective way? The personal arm, but now versus being a nurse, is just, it could be anybody. It's just somebody that we've trained to call back. And so we will do this at 2 years and 3 years to see, because the idea is, can you get repetitive testing done? So this is a big difference between this and the R01. 90% of participants have reported of hearing CRC screening. When we were doing the R01, CRC screening was just coming to the forefront. And so there were a lot less people who had heard about it. Now, however, only 64% knew it could name a test that you could check for CRC. 70% reported that their provider had recommended screening in the past. 91% who reported they'd want to know if they had CRC screening. And 90% indicated they would be able to return the test in the mail. You just had to say, can you mail it back? So we've had 599 patients enrolled to date. 300 have been in the automated arm, 299 are in the personal arm. We had an overall rate of 69% completed test. We've had about 10% which are positive, which is about the rate of the FIT testing, which means they need to have a colonoscopy done. The clinics take over when they get a positive test. They just go through their normal procedure. They have hospitals that are willing to do it for indigent patients who can't afford to. And they had 8 that were outside the lab window. You only have 2 weeks to mail from the date you put on there you do the test to the lab getting it to be able to analyze it. And so we had 8 who sent it in, and the majority of them, for whatever reason, it was 3 weeks out. And so the lab won't analyze it. And so in those cases, we send them another one and say, you had an issue. We need to do that. So in the follow-up calls, in year 1, and this is the first one where they were handed it in the clinic, 113 people were called, 26 returned their FIT. So that's 23% of the people who were called in the automated arm completed it. 12% of the completed FIT in the AC were the result of a call. In the personal call, 115 people were called, 22 returned it, so there's 19% of the people called, completed it, which is 11%. So you can see there's not very much difference. And honestly, where I thought we were going to start seeing the difference is when we mailed off the kits. And so this is the results to date, because we're just now mailing out year 2 kits. 48% have completed the kits, so we've dropped off some. 2 have been positive and 2 were returned. 44 people have been called in the automatic call arm. 10 have returned the kit. So 23% of the people called completed their FIT, which is about the same as what it was in year 1. But if you look at the number of completed FIT, and that should say AC instead of PC. But if you look at the number of people, 35, almost a third of the people who completed that kit in year 2 had to have a phone call. So it was more than in year 1, which is what we anticipated. And it's the same with the PC arm. 41% of theirs, they're down a little bit more in their screening rates. 19% of the people called completed their FIT, and 32%. So it's still a third of their patients. So we have no papers yet, although we've started on them because we've just gotten through year 1. But so far, we've had 10 abstracts and posters presented. We have one of our nurse practitioners who is a co-investigator on it, who presents at conferences for nurse practitioners. We have had our research associate present. We have presented at health literacy conferences. The other thing I will tell you about grants is every year when you do a grant, you have to do an end of the year report. Even with NIH, they are very interested in seeing that you, regardless of who it is you have on your team present, they're very interested in having the data that they funded out there. And so it only behooves you, not only does it help research for students or fellows or residents, but it also helps you in what you end up filling out for the institution and for the organization. So from the ACS comes a GI fellow and a medical resident study. So one of the GI fellows decided that she wanted to do something here in medicine clinic. And she came up with the great idea. We ended up getting funding from Christus Schumpert. It was just a small amount of funding. That she wanted the physicians to do it. So it's a physician-directed, so the physicians are residents in medicine clinic. And one of the objective was to see if they gave the brief physician-delivered education, which they used the ACS materials, would it make a difference? And so we recruited resident medicine residents interested in doing the study. We initially had 6. We added 6 more. They were randomized either to giving an education arm or they were giving just the enhanced care, which means they just handed them the kit. And then that's what that says, is that the residents also use Teach Back in the educational arm to show the patient how to do it. One of the interesting things about this, I don't know if I took it out, let's see, is that Pega did a YouTube for this. So she did a YouTube video, which is really creative. The residents who were in the education arm had iPads that they carried in their pocket. And so when they went out to do something, they would show the patient a 2-minute YouTube video. And it is simply of Pega demonstrating how to do the fit kit. And so that was a really cool thing that she ended up developing. And they used the same instructions we did with ACS. And there's it was just a step-by-step with her showing patients how to do it. And so one of the problems with this study is recruitment is very slow because medicine residents changing schedules. We have to have our RA go over and do the survey. They have to call the patients ahead of time to see if they're going to be interested. But they got 32 patients enrolled. With negative results, the residents had to generate a letter. With positive results, the resident calls the patient to discuss the results, and actually the GI fellows who are involved actually set up and do the colonoscopy. So even out of that tiny study, there have been 4 of them who have submitted abstracts or presentations. And that's 32 patients. So from that led to our research associate, Jill Hancock, who defended her thesis today, taking the ACS and the fellow study and thinking about colonoscopies here in this institution. And we had a master's student before look at what patients' knowledge were if you gave them simplified instructions. But Jill decided to try, with the help of the GI staff and James Morris here and us, develop more simplified instructions. I don't know if you're familiar with what patients are given. It's a 1-sheet colonoscopy instructions, and it's about colonoscopy prep. And so we simplified the instructions. That's Jill. She would kill me if she knew that we were eating in New Orleans when I took that picture. So we took the information, which was already simplified. It was just it was somewhat simplified, I should say, but it was disorganized chronologically. And I actually did a colonoscopy with those instructions. And you get about halfway down the page and you realize that out jumped 7 days before this. And I thought, oh my God, 7 days, I'm past the 7-day window on this. So, and these are the instructions. So the ones on the left are the original ones. So you see, it's not like it's a ton of information. It was a 9.6 grade level. The ones on the right use everything we know about health literacy. It has headers. It's in chronological order so that when you read it, what do I need to do 7 days out? What do I need to do 3 days out? What do I need to do the day of my colonoscopy in order to get ready? And so these are printed out in University Health Hospital. And so what Jill decided to do was do a retrospective study. This is of real patients who've had it done, and just have charts pulled and then do a chart review of patients who had the original ones and then patients who got the new ones. And so she ended up having 1,126 records returned, and through various reasons, she ended up with 477 in the final analysis. And what she found was that the simplified instructions, after looking at 3 months before we instituted and 3 months after, one of the big things is patients often show up, and when they're discussed at pre-op, is that, have you not made sure they haven't eaten anything? And they'll go, well, I ate a hamburger last night. Well, we can't do your test today. So they have to go home. So there's a lot of waste of appointments that patients get canceled. They don't bring somebody who can stay. Somebody shows up with them, but they're leaving. They're not going to stay. In order to have a colonoscopy at LSU, in University Hospital, you have to stay the whole time. So it dropped from 10.5% of canceled appointments to 3.2%, which is a huge cost saving for University Hospital and is a huge benefit for patients. And then there was an increase in patients who were adequately prepped. And so James Morris, who is the GI who was involved in this, had anecdotally told us the same thing. He said, I had on average 8 to 10 patients who would show up who they were unprepared and we couldn't do their colonoscopy, and that's dropped from 1 to 2. So the last study I'm going to tell you about, which is a good example of what happens when you get slammed and what to do to come out of that, is a study that Rick Mansour is doing that submitted over in Feisweiler for sickle cell patients. And Rick is a huge advocate for his patients and is very passionate and concerned about his patients. And this was a UO2 he asked us to help with, and this was something I don't recommend doing, and this is just my personal opinion. It's a throw it together grant and just slam it in there. Because usually what happens is they just slam it right back to you when you get your critiques. The grant was not reviewed. It had some scathing critiques. There were some scathing reviews about Rick because Rick has not done any research. And one of the things as a reviewer you look for is if you haven't done any research in the topic area, do you have somebody either as a consultant or a co-investigator on there? And we made some critical mistakes, and I would say that one of them is just sending it in too fast and not prepared. So the good thing about Rick is he just takes it in stride. You know, I mean, he looked at those. You just have to be able to take criticism and just let it go when you submit grant reviews, because reviewers sometimes are just very brutally honest about what they don't like about you. What they don't like about you, what they don't like about your grant, what they don't like about your methodology. So he took it in stride and he said, you know what? He said, I have to do some research before we submit another grant. So he has done a sickle cell study. He is over the sickle cell clinic there, and he has done a couple of things. He has all of his patients enrolled. I think there's over 400 in a registry over there. But he and his fellow Samit masters decided to do a study on 100 of their patients. And one of the things that really ticked me off on one of the reviews, because I do take this personally, was one of the reviewers said, I have no idea why health literacy is involved, and it has nothing to do with sickle cell. So one of the things we looked at was characteristics related to anxiety, pain, depression. We also looked at literacy among their patients. And it was just a convenient sample. They did 100. When I ran the analysis that they had given me, there were 98 patients. He had a research assistant administrator who was trained over there who administered it. So this is with no funding other than Feisweiler allowing one of their students. It was these were college students who did the administrative. And they did demographic questions. The promise questions are designed for patients at all literacy levels. And they did a pain intensity, depression, and anxiety survey. They did Callahan's 6-item cognitive screener, and they did the shortened form of the realm. And so that just kind of shows you, if you have any curiosity, the promise is free. You can actually get it off of the website, and they have numerous ones. They actually have a whole sickle cell battle of questionnaires now. But this is, I felt fearful. I found it hard to focus on anything. I felt uneasy. So you can tell it's fairly simple for patients to answer. All the questions were administered orally. So, per the reviewer who said, I have no idea why literacy is involved. This is the first study that I have ever been involved on that we had no one who scored in a 9th grade or above literacy level. Even though you had 14% who had college graduates, had graduated from college. So literacy is a huge issue. And so one of the things that Rick was interested in, when you look at, there was no significant cognitive impairment. When you looked at depression, you get T scores on the promise, and it's how you compare to the average adult. And so With depression, they were mildly higher than the average adult. With anxiety, they were similar. Pain intensity, they were mildly higher, which isn't surprising because if you notice, they're on 108 milligrams on average of morphine because these are sickle cell patients. But you did notice a moderately higher interference, that pain interferes with their daily life. And so what Rick has done and what we have done is I know they've submitted 4. They may have done more of that to ASCO. We submitted an abstract to the Health Literacy and Research Conference that got accepted for a poster. And so what this does is it lays the groundwork for an R01. It lays the groundwork for what you get criticized for, which is, even though that is his clinic, he is the one who sees all the patients over there, he has no research experience in that. And when you're writing grants, that's what they're looking for. And so what he was interested in doing was just slowly plowing along and going, okay, I will build up the research. I have access to the patients. I have access to this. I can do this. And so he's putting one foot in front of the other to do that. And it all adds up. So since 1998, I've advised minority high school students, college students, graduate students, medical students, residents, faculty, junior faculty. Of these, 41 have given oral presentations as first author out of 77 presentations at regional and national and scientific meetings, and 16 were first or co-authors on at least one paper. So it's a matter of just finding ways to include students. It's a matter of finding ways to just do research that interests you. You know, Terry and I never had necessarily a passion about smoking or immunization. What our passion was about was health literacy. And so part of it is you have to be realistic and go, okay, where is the funding going? Because just like with NIH, funding changes. They have different priorities, and you have to be able to be a little bit flexible and go figure out where is it going and how can we incorporate what we're really interested in with doing that. The other thing that I will end this with is, for the last 13 years, I've been a reviewer on NIH grants, on HRSA grants, and on CDC. And so these are lessons that I would tell you as a reviewer. Know what you are writing for. You have to read what they're asking for. Follow the instructions on what they're looking for. Here's one of the things I will tell you as a reviewer. If you make me dig for that information, your score reflects it. If I have to get in there and dig and find and you've irritated me, I can remember when Terry and I wrote a Robert Wood Johnson grant, and they got so many grants, and like you would go past the first level where you actually got invited to a meeting. And one of the grant reviewers got up there and said, if you cannot catch my attention within the first couple of minutes, I will not waste my time with you. I mean, that's just the nature of the beast. Now, when I review NIH grants, I will read it no matter whether or not you've caught my attention or not. The problem becomes is if I have to dig, if I have to really search for trying to answer the question, if you confuse me by throwing the kitchen sink at it, then you are more likely to get a much worse score. Because NIH reviewers tend to have, usually when I review, I have 10 to 12 grants that I have to review. And so you're just trying to get through them, to analyze them. It also is kind of like the Wizard of Oz when you're a reviewer. The curtains pull back and you get to see what really goes on behind the doors. You know, you get to see how your first reviewer, if they hate your grant, can tank you in a matter of minutes because they're the ones who are going to present it to the committee. If you don't have the CV, like when Rick didn't, with prior experience about the topic or research with it, then add a consultant if there's nobody here at this institution who has a CV, or add a co-investigator if there is somebody here. Ask someone who's reviewed grants before in your area. It always helps because by the time you finish with the grant, you're so embedded in that grant that you can't see your own mistakes. And it's clear to you because you wrote it. It's clear to you because you picked the topic. I would say, and this is where some people disagree with me, I do think it matters if you just throw it together. You know, some people's philosophy is just get it in and get the reviews. Well, like with NIH, you only get one shot to go back. So if you have big flaws, you have one page to address all 3 reviewers' criticisms. And if what they hit you for first are the big flaws, when you go back in that second time, then they're going to start looking for the nitpicky stuff that you really want them to do on the first review. And put your ego aside. Some of these reviews are really painful. They really are. And some people are more tactful than others when they send you back your grant reviews. But also, you have to realize reviewers miss stuff. You know, I mean, we get reviews back all the time, and I'll go, but that's in there. Reviewers miss stuff. It's 12 pages of very heavy, dense material. And you've got, you know, 10 or 15 of these to review. You miss stuff. And so instead of being snarky when you send back your response, you just need to point out where it is and go, thank you for, you know, we appreciate your comments, and here's where it's located. But research, as I've learned in the past 24 years, really is about putting one foot in front of the other. And so for me, the whole issue with including residents, including fellows, you know, we've had medical students who've come up with their own idea before. We had a derm study that was done in clinics, but that is a long process, and it is especially a long process in the environment we have today with IRB and everything. And so part of it is, can you hook up with somebody who's doing research in an area you're interested in? Can you tag on to something they're doing it? And as a faculty member, you know, what I would encourage you is to think of ways that you can include fellows and residents and medical students in the research that you're doing. Because not only does it benefit them, it benefits you. It benefits you in lots of ways. It makes you think differently. It also helps your CV, and everybody's always looking at their CV when you're on the faculty because you're always looking at promotion. So, but that's really, today I just kind of wanted to give you an idea of this is how Terry and I do it. This is what we've done over the years. This is what worked for us. I can tell you we have been rejected more times than the number of grants we've received. And that's just and that just really is the name of the game. I think probably in this day and age, you really have to look for other sources outside NIH. You have to look for grants in divisions that you're in. You have to look for community grants. You have to look for state grants and those kind of things, because NIH funding has just shrunk so much, and the competition is so incredibly steep. It's not to discourage you from going after it. It's just, I would say you need to have your ducks in a row when you do. Thank you.